Hello, everyone. My name is Teresa Jacobson Kimberly. I am a professor and the director of the Brain Recovery Lab at the NGH Institute for Health Professions. I'm very excited to be talking to you today. I am a big fan of the NSDA and the group that works so tirelessly to help support research, um, education, and resources for people with spasmodic dysphonia, or as I'm going to refer to it, laryngeal dystonia. So my talk today is to give you a brief introduction to the pathophysiology of dystonia and to tell you a little bit about some work that we're doing in my lab. So the title of the talk is Dystonia is All in Your Head, How We Know and What to Do About It. And this is a play on the words of this is all in your head, because many people, unfortunately, with a diagnosis of dystonia were told at some point along the way that it was somehow in their head and that it wasn't an actual neurologic disorder, which indeed it is. I have no disclosures related to this content. So what are we going to briefly talk about? Number one, my objectives for you at the conclusion of this are to appreciate the link between spasmodic dysphonia, i.e. laryngeal dystonia, and other focal dystonias. Number two, understand how non-invasive brain stimulation with transcranial magnetic stimulation, which I'm going to refer to as TMS, can help us learn about spasmodic dysphonia, and understand what neuroplasticity is and how it relates to recovery. And finally, consider how neuromodulation might be an important adjunct to treatments in SD. So I became interested, I'm a physical therapist, which you don't see a lot of PTs that study voice disorders. I became interested in SD through other kinds of focal dystonias, namely hand and neck. So the woman are demonstrating right here is you can see her cervical dystonia. You can see the muscles in her neck are spasming and preventing her ability to turn her neck. The person with the video right now in her hand is, you can see how her fingers are involuntarily curling while she is attempting to write. This is focal dystonias are also common in musicians, and here's the pictures here show some examples of finger dystonia or embouchure dystonia that is preventing them from being able to play their musical instrument. So focal dystonias have an unknown etiology. There is nothing wrong with the muscles themselves. So the muscles themselves are healthy muscles and can work and do other tasks that when it's not related to the task that is associated with the dystonia. So in the case of the person with the hand dystonia here, the writer's cramp, she can type on a keyboard or use her phone or pull keys out of her pocket or button a shirt with no problem. It is when she picks up the pen that the problem starts. Same with the musician's dystonia. It's the instrument. Cervical dystonia is a little bit different in that the trigger is more gravity, so just sort of holding the head up in space is the trigger. But in laryngeal dystonia, the trigger is speaking, as you all know. You don't have problems with just creating a Valsalva maneuver, just tightening your muscles like that. Many of you probably have less difficulty when you sing or whisper, and you can make non-word noises without problems, such as crying or a whimper, something along those lines. We have no diagnostic marker for laryngeal dystonia or any focal dystonia. You can't do a test and say, oh, you have this. It's often an elimination of other problems, which you have probably all experienced. And you have no other pathology that can explain this. So you don't also have Parkinson's disease, or you don't also have a stroke. And most frustrating, perhaps, is that there's no effective long-term treatment that is known. So it turns out that what we do know about dystonia is that the problem is indeed in your head. As I mentioned before, it is not in your muscles, it is in your brain. So I direct the Brain Recovery Lab. So for the last 20 years or so, I've been examining brain disorders and how to better identify the causes of them, and worked on developing new treatments, interventions. One of the principles that guides us is that all learning, including relearning or recovery, is represented neurologically by changes in the brain, which we refer to as neuroplasticity. So you can't learn any new task, like you're a child and you don't know how to tie a shoe, and then you learn how to tie a shoe. That is represented, that's in your brain, that motor control has happened. You don't know how to play the piano, and then you learn to play the piano. That produces reorganization in the way that you trigger, I'm looking at that note, and that means I press this key. All of that is neuroplasticity. Neuroplasticity is also experience dependent, meaning you have to actually do stuff in order for the plasticity to occur. You can't just solely think about something or read it in a book. You have to actually do it. Neuroplasticity can be good or it can be bad. So in the case of learning to play piano or tying your shoe, we think of it as good. Or if you're recovering from a stroke, you had a stroke and you lost ability to function, you can work through rehab to develop new connections, and you can recover some of those abilities. But it can also be bad. And dystonia is one of those things that we think is related to neuroplasticity gone too far, that it reorganized in a way that is optimal, and then it just kept going. So why did it keep going? So the reorganization kept going so that it became dysfunctional. There are tools that we can use to measure this. One is neuroimaging and one is non-invasive brain stimulation, where we can understand how that change has occurred, and we can compare between groups to better understand it. We also think that neuromodulation, which changes the activity in the brain, may be a useful adjunct to treatments. So I'm going to briefly tell you about TMS. So we know about brain scans. Likely you've all had one. This is an MRI of some sort. We get a nice picture of the anatomical picture of your brain. But TMS is a little different, that we put a coil on top of your scalp, on the top of your skull, and we send a little electric pulse through it, which creates a magnetic field and a secondary electric field that then stimulates whatever's underneath it. So if I do TMS on my arm, here through my shirt, I can stimulate it, and my extensor muscles in my wrist will contract and my arm will go like this. It just feels like a snap, kind of somebody just tapping you. But if you do it on the brain, we can activate those neurons that are underneath it and make them fire briefly. And that signal then travels down the brainstem and spinal cord. And ultimately, depending on where we move this coil, it'll make that muscle respond. So we can use it in different ways to determine the amount of excitability in a brain, both in a given hemisphere or between hemispheres. So this is a picture of the coil here on somebody's brain. It's kind of like experiments in my lab are kind of like going to the spa. You get to just relax in this nice reclined chair. There's our little stimulator that gives us the pulse. This is 2 electrodes that are taped onto the muscle of interest in the hand. And this is a little preamplifier that makes our signal stronger. This is a ground electrode bracelet. And what do we get? So I stimulate here, and then of course it crosses because the right side of the brain goes the left side of the body in terms of the limbs. And I'm recording from over here, and I get this, it's called a motor evoked potential. Shoop, I get this nice little ping of activity in the EMG signal. So why am I telling you this? I find this is a nice measure to talk about because it's very intuitive, because you can visually see the difference. So this is something called a cortical silent period. So if I have you contract your finger and then I hit the TMS pulse on the area of the brain that controls that muscle, it will briefly interrupt the signal to that muscle and cause a silence. And we can see that in our EMG trace here. So here, somebody's contracting, making just a tiny contraction. And then there's the TMS pulses here. And then you can see first there's this big facilitation of activity, and then it goes away and it's almost silent, and then it comes back. You barely perceive this if you're receiving it. You can hardly tell that anything happened. You just think you're still pushing on this little lever. And we know that the duration of that silence relates to an inhibitory measure in the brain, an inhibitory neurotransmitter in the brain. So we can essentially quantify it. So here, we're looking at the difference between a healthy person and somebody with dystonia. So this person had focal hand dystonia, and you can see how much shorter their silent period is than the healthy person's. So this means that the person with dystonia had significantly less inhibition than the healthy person. And we've looked at people with hand dystonia as well as people with adductor spasmodic dysphonia, and in their hand, and we have found that both people with hand dystonia and people with laryngeal dystonia, in this case adductor spasmodic dysphonia, had less inhibition than healthy people did. So this tells us that the loss of inhibition is not specific to the muscle that is affected by your dystonia. We also looked to see if it could help create, this measure could help create an understanding of a differential diagnosis between muscle tension dysphonia. Maybe some of you, when you were first diagnosed, were told that you had muscle tension or they didn't know if you had muscle tension dysphonia versus laryngeal dystonia. And often the way to tell the difference between those two is simply, does it respond to voice therapy or not? MTD does, and SD does not. And we found that there is a difference in people with MTD than SD. So this has potential to maybe help with that differential diagnosis. Nobody had looked to see, however, how this measure works, this silent period, how this works in the muscles that control the larynx. And so we first did a project where we were just trying to figure out, can we put tiny little electrodes, you can see them here, these little fine wire electrodes, can we put those in the thyroid muscle, which is also called your vocal fold, and do this same measurement? And so we found that we could. So there you can see these electrodes in the vocal cords are activating with this burst when the person is phonating. So there you can see she's making these little bursts of E, 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 and we know that we're in the vocal cord because we see this nice little burst. So interestingly, when you have these little wires in, they don't hurt. They're just so, putting them in requires a needle, which is pokey. If you receive Botox injections, I'm told it's easier than that because it's just an in and an out. But when we put it in, then the electrode is left behind, and then the needle comes out. So we did this examination. We wanted to see what the difference is in the larynx, and we found that here's the difference between control healthy people and people with ADSD, with their difference in their silent period in the hand, and then this is in their larynx. So these are the healthy people. You have two muscles, two vocal cords, and each vocal cord is actually controlled by a hemisphere. So this hemisphere controls both, this hemisphere controls both. So we had to look at actually 4 comparisons, and we're grouping these all together. The control were also had more inhibition than the people with laryngeal dystonia did. So what is this? It's interesting. It tells us a little bit about the pathology, and that laryngeal dystonia isn't the same family as other dystonias. there was some question when I was first in this field that is it really a dystonia? But it seems to behave the same as other dystonias do, so it probably should be considered along with other dystonias. This is good because your community is now bigger. So now it includes research and expertise in people who understand a bigger, many more people um, are being studied, or different kinds of researches could potentially, that's happening in cervical dystonia, could potentially lead to advances in understanding laryngeal dystonia. But so what is this? How is this useful for somebody who has this disorder? Well, that same brain stimulation that we use to test brain inhibition or excitation can also be used to modify brain excitation or inhibition. So this has been used in a variety of disorders. The one with FDA approval is depression. So rTMS, repetitive transcranial magnetic stimulation, is FDA approved for treatment in people with depression. I believe that most insurance companies do not pay for it. So it is something that is considered a cash payment. People who get this for depression, they stimulate a different part. It's not a motor disorder. They're stimulating more in the frontal lobe, in the part of the brain associated with emotion and other kinds of brain activity. But it's also been studied, this rTMS has been studied in people with stroke, Parkinson's disease, hallucinations, seizures, and people with dystonia. The stimulation parameters were very much in our infancy because there's a lot of different ways that you can stimulate something. You can try to increase excitation. You can try to decrease excitation. You can try to increase inhibition or decrease inhibition. Believe it or not, those are different things. They're kind of like a gas or a brake in your car. They're different pedals. You can stimulate before or after a different intervention. You can, how many times do you have to stimulate? How long should you stimulate? All of these things are things that we're just beginning to investigate. So why would you want to modulate? Well, like I was telling you about the car analogy, the gas brake, putting on the gas or letting up on the gas is not the same as putting on the brake. And what we want in our nervous system is you want a balance of excitation and inhibition. So you want to be able to work that excitation pedal, and you want to be able to work the inhibition pedal. And in the brain, unlike in the car where you don't want to be stepping on those at the same time, although my father does drive that way, 2 feet. The brain, you can have both going on at the same time to help balance that system out. But things can go wrong. You can have too much excitation, or you can have too much inhibition. So this optimal state, this healthy state, we think of as creating an ideal framework for your brain to operate on, to have all those neuron connections to operate on. So how do you neuromodulate? I mentioned this earlier, repetitive transcranial magnetic stimulation. You deliver this pulse in a repetitive stream for 15 to 20 minutes. If you do it at a slow rate, about 1 hertz, which is once a second, it increases the inhibition. If you do it at a higher rate, it can increase the excitation. There's a little bit of nuance in this, but for the most part, we can think of it like that. In terms of safety, it's a very safe procedure. It's been around for 20, 30 years, and there's very few serious adverse events that have happened. The biggest risk is that it has caused seizures in people. Very few. I've forgotten the total number now. I want to say about 20 people in the history of TMS that have been documented, but it can happen. All of the seizures that have occurred have been when people are using TMS to increase the excitability. So the study I'm going to tell you about, we are trying to increase the inhibition, and there have been no documented seizures related to that. Nevertheless, it's something that we ask about before somebody would participate, because we just want to be extra careful. the most common side effect is headache, and it feels, I've had TMS a bazillion times from different experiments and practicing and things, and it's kind of like somebody is going like this on your head. And if somebody does that for 15 minutes, you may get a headache. If people have severe migraine that's easily triggered, it might not be something that they want to try. So we've used this RTMS in people with hand dystonia. I'm just going to show you, this is probably the most interesting thing to look at here. Here's somebody writing on a pad. We have this digitized tablet that allows us to look at pressure and the trace of their hand and quantify that. And you can see how variable this is, very wiggly. And there's lots of pressure. This here is the change in the amount of pressure. This is after 5 days of treatment. So you can see that their writing smoothed out and got a little more legible. This is how much pressure changed. Oh, I'm sorry, this is after day 1. This is after the week, 5 days of the intervention. We also did this combined with some sensory training in one of our studies. And here we looked at the change in that CSP measure. So people with dystonia have a very small CSP. After the 5 days of treatment, that CSP lengthened. So again, we're trying to increase the inhibition. Oh, I forgot to mention this one. This one was a 9-day follow-up when they came back after not receiving intervention for a few days. So we've done this in people with laryngeal dystonia too. We did a little pilot study. And what did we find? Well, part of the problem was that some of our people were so severe that with their laryngeal disorder, because we tested them when they were at their worst, immediately before they were going to get their Botox injections. And we tested 8 people, but we only had enough samples, 3, 4, 5, to look at 5 people. But you can see here, there were these 5 people at pretest. This is a measure that looks at how much disorder is in a voice. That's common with dysphonia, recommended for people with a dysphonia. And you want to have a higher number is better. So people, you can see here, this was just one session. So immediately before the one session and then immediately after the session, you can see that for 3 of these people, there was a slight increase. 2 of the people stayed about the same. And here we had a favorable change. This is the number of phonatory breaks. So that's how often there's a catch in a voice when somebody's speaking. And you can see that there's improvement in 4 of the 5 people who had a favorable change. Another kind of improvement is just looking, or I shouldn't say improvement, another change is, did that CSP change? And I'll say that in the literature, we don't always show a correlation between CSP change and clinical change, but it did look in this particular individual. They're looking at a whole bunch, there's 50 samples here where you can see, here's the TMS pulse. Here's that little facilitated piece. Remember, this is the electrode is in their vocal cord. And here you can see a silence, then it comes back. And then this is post. You can see a silence. It seems a little bit longer after they came back. Let's see if this works for you all. You'll be able to hear this actually, but I'll play it. I can't even hear it. Okay, that was really quiet. I'm gonna play that again. Apologize, that one's so quiet. Here's a post test. So the patient in my ear says that that second one was a little bit more smooth. And these are very subtle changes. But the point of this study was to say, is this feasible? Can we do this RTMS in people? Will they come and receive the treatment? Is there any signal that we may be onto something, that this might be worth continuing to investigate? And when we looked at all of this evidence together, we decided that yes, it is. Now, the talk of neurostimulation makes me want to make sure to caution you that there are a whole lot of devices on the market that will be happy to take your money and do virtually nothing for you. And that is, this is just one where people advertise, these companies advertise that this is going to put electric current in your brain and help you get better at whatever. This one is related to doing video games better, like improving your motor control related to video games and things like that. Well, I will tell you that none of these are what I'm talking about. The amount of stimulation is very, very, very different. It's not targeted. It has no evidence that it would be beneficial. So we're doing the study. And now instead of just doing the one day, because we didn't expect that to have a clinical benefit, we are going to do 5 days. So there are 2 phases. You're going to have, if you would participate, you would come twice. You would come once, and we'd see you Monday through Friday every day. We do some testing, then we do the RTMS, and then we do some post-testing. And then the next day, you just do the RTMS, 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 and then no posting. And then the next time you come back, it would be a control intervention where you're getting just a tiny bit of the stimulation. And you won't know which group you're in. You hopefully would not be able to tell which group you're in, but we need people to do both phases because we want to compare the changes associated with the higher level of treatment and the low level of treatment. Because as you all know, there is a normal variability in the kind of and how your voice behaves. So we want to try to eliminate any just regular changes that might just happen randomly, or a placebo effect of where you think you're getting an intervention that causes people to sometimes have a positive response, a small positive response. With this, you would have to come to Boston. We have a small stipend to help offset those expenses for if you have to travel a long ways. It is a big time commitment because we would need you to stay for the week. And then you'd have to come back at least 3 months later, approximately 3 months later. If you receive Botox, you would need to do it at the end of your Botox session or when you are ready to have your injections again. And then we would need to time the next batch, the next visit at that same time. We'd also have a follow-up, some phone calls related to that after you've completed it. If you're not getting Botox, you're still eligible to participate, then the timing is just a little bit easier. Here's some details on our inclusion criteria. We need you to have either abductor or adductor spasmodic dysphonia. Thanks to funding from the NIH as well as the NSDA, we are able to include both groups to fund them to be able to try to see if this is effective. One piece to note is that I want to make sure that we're managing any expectation that we do not think that this would be a cure for SD. My hope is that we could figure out how to make this perhaps reduce your symptoms or extend the time between your Botox, potentially reduce the dose of Botox that you would need. It would be somehow used in conjunction with other treatments that are working well for you. But we do not think that this would cause a permanent change in your disorder. The hope is that it might help. If we can find something that helps, and perhaps we can learn how to do that even better or better or better to eventually lead to something more dramatic. But this would be a first attempt to see if there is any lasting benefit, in which case then probably a real clinical treatment associated with this would require more intensive treatment, perhaps similar to the depression literature, which has people receive the treatment every day for 4 weeks. So it's a really intensive treatment that then lasts for a long time. So potentially that might be another way future work to go. But that is our study, and Russ can tell you more about the study and answer specific questions in terms of whether you may qualify or not, but we'd love to have you reach out if you're at all interested. The thing, some contraindications, you can't have a metal in your brain, like a piece, like an aneurysm clip or deep brain stimulator, a cochlear implant, that kind of thing. You can't be pregnant or have a bipolar disorder, and you can't have had a seizure in the last 2 years. So we have a lot of work to do, but this is our first step in trying to see if this the science that has told us about the pathology can help us develop a potential intervention. We need to understand if there is a measure that can tell whether or not this is working. And then we want to figure out who is likely to respond to a treatment. So it could be that half of the people who get this have a good effect and half do not. So we want to be able to understand what that is so that we can make better recommendations to people. Of course, we need more funding for continued research so that we can continue to make these discoveries. And we need people to participate. Clinical research does nothing if people do not help. And we have roles for healthy people as well as people with laryngeal dystonia. We would very much be appreciative if you would consider reaching out to us and potentially participating. There's our contact information. And I need to acknowledge all of my fabulous collaborators and all of the funding that we have received over the years that have really helped us make these discoveries. And with that, I'll stop and say thank you for your attention. I'm sorry I cannot be there in person. Hope this was helpful.